We must put people first if we are ever to end the HIV pandemic as a threat to public health. That's what person-centered care is all about. Almost 1,000 stakeholders across the globe have been directly engaged through the program so far. We are seeing the real impacts a person-centered approach can make.
In Baton Rouge, the southern sector, you see nice roads. You really don't see poverty. You go to the northern sector of Baton Rouge, I see abandoned buildings. I see infrastructures that need to be fixed. There is great division. And it also occurs in the HIV organizations. I started working at a nonprofit and I saw a lot of people looking like me. And by that, I mean people that experience homelessness, intimate partner violence, people that identified as the queer community or as a Black person. And I saw all these systemic issues, these social determinants of health. Across the southern United States, healthcare becomes about, well, what are the provider's needs? As opposed to, what does that individual need? That might be housing, that might be food. You're telling me I need to take this medication. Well, I care less about medication. If I haven't ate in 2 days.
We must strengthen health systems and advance policies that enable broad and equal access to medical innovations. The IAS Person-Centered Care Program embodies our commitment to putting people at the center of the HIV response. Together, we're working to create a multidisciplinary approach to care for people living with and affected by HIV.
I work for an organization called CHIB Zambia, which is providing community-based HIV services for key populations. Here in Livingstone, which is Zambia's tourist city, and also the huge transit city with a lot of people affected by HIV. We started by setting up clinics in the region and saw the primary health services getting congested.
Individuals living with HIV who are on treatment can now live healthier and longer lives. The challenge is that we know 40% of people living with HIV will disengage at some point in their HIV care treatment. I hope that we can close the last mile, and I think person-centered care is at the core of this.
Person-centered care, when done right, they're led by individuals in the community. It's a full circle moment where they do testing, they also do harm reduction, specifically around people who inject drugs. The organizations like that have a true impact on the community. As a person living with HIV, I understand the need for community and the need to serve the community.
We have come up with a model here in Livingstone where we have key population members who've been trained as community health workers that are actively participating in the delivering of these services in a peer-to-peer approach. And this has really helped to bring down stigma and discrimination and fear of being criminalized. And decentralizing these services has also helped to decongest the facilities.
Person-centered care means recognizing that there's no one-size-fits-all approach. Everyone's experience with HIV is different. It's understanding that quality of life goes hand in hand with quality of care. When communities lead, care reflects their realities and becomes fairer, more inclusive, and truly people-centered.
I started in the IAS program in a partnership with Gilead, going to the academy. It focused me on person-centered care. Didn't know I was doing that on my own until that training even came about. We really don't get opportunity just to sit down, talk, engage on that level, where it changed the trajectory of even my research focus. The research project that I'm doing with IAS through the grant is really focused on validating the measure for quality of life for Black, same-gender loving men. So by moving this forward, we have this person-centered care measurement that providers can use in HIV care. You take the time to really get to know the individuals that you're speaking with, really make them feel involved, and by ensuring their needs are met, they're going to continue to come back.
The seed grant awarded through IAS PCC program has been instrumental in advancing my research work. It started with training data collectors from the key population community, and we deployed them in the community to collect data from the recipients of care. We also conducted focus group discussions with female sex workers and in-depth interviews with the community health workers. the research has really helped to gather evidence that is going to influence policy change in terms of how these peer-led services are going to be provided in the community.
As we're trying to advance the science, we have to work collaboratively to make sure that interventions are built on evidence as well as informed by the needs of communities, partners, and collaborators.
We are funding grassroots research and learning directly from people and organizations on the ground to find out where approaches are working, but also where they are not and how we can do better. It's about empowering communities, connecting key stakeholders, sharing knowledge, and creating solutions that are durable and long-lasting.
My lived experience is my advocacy. I want to ensure that everything that I went through, other people do not have to go through. We really want to focus on policy and making these systemic changes. The IAS Academy said, if you're not going to open the door, who is? To ensure these systems include us. And if they don't include us, kick down that door, walk through it with your purpose, and make sure your passion and motivation drives you forward.
My message to global health leaders is that person-centered care is not optional. It is essential. Look at person-centered care as an investment as well as a human right that is going to support ending the HIV epidemic.